As with men with hemophilia, bleeding disorders have a significant impact on women's health. They are an important part of our global family. Women with bleeding disorders suffer reduced quality of life that negatively affects academic, professional, and social achievements. Many women are not aware that they in fact have symptoms that are abnormal, and thus they do not seek medical advice. And even when they do seek help, diagnosis of the underlying bleeding disorder is often overlooked, and appropriate treatment is not provided because of the lack of training and awareness of healthcare professionals and caregivers. Therefore, these women are more likely to have unnecessary surgical interventions, including hysterectomy at an early age. They deserve better. And I'd like to share with you how the World Federation is going to work to change this. The graph you see here shows the proportion of male and female patients for all bleeding disorders. The men are in blue and women are in red. Since 2008, the WFH Global Survey reports gender by data and country. And although hemophilia disproportionately affects men, shown in the two bars on the right side of the screen, other inherited bleeding disorders do not discriminate based on gender. According to our global data, the gender split for other bleeding disorders is relatively equal. So let's look even more globally. Worldwide, over 220,000 people have been identified with inherited bleeding disorders, reflected in the blue bar on this graph. In large part, this is accounted for by the rapid improvement in diagnosis and care for people with hemophilia. Nearly 150,000 people with hemophilia have now been identified, reflected in the purple bar. However, for other bleeding disorders such as von Willebrand disease, the recognition and level of care has not developed similarly. VWD is shown in green, and the other bleeding disorders, which include the rare factor deficiencies and inherited platelet disorders, are reflected in red. VWD is considered the most common bleeding disorder in the world. VWD prevalence estimates range up to 1.3% of the global population, although all may not have clinical symptoms. Since the WFH began collecting data on von Willebrand disease in 1999, only 52,000 individuals have been reported worldwide. Of those reporting, approximately 40% were men and 60% women. For most families, there is a history of a bleeding disorder, but it is often unknown. In recent decades, it has been recognized that carriers may also have low levels of clotting factor, meaning by definition, they too have hemophilia. However, carriers are a significant and often neglected member of the global bleeding disorders family. 20% of true genetic carriers have factor levels under 30%. Additionally, other carriers with higher factor levels in the range of 40 to 60% may have increased bleeding tendency as well. Although most carriers will be asymptomatic in day-to-day life, some experience significant bleeding symptoms. The reported incidence of carriers per male with hemophilia varies significantly within the scientific literature. The difficulty in accurately defining this figure lies in the fact that most women who are not mothers or daughters of someone with hemophilia simply don't know that they might have a bleeding disorder. Estimates range from 1.5 to 5 genetic carriers per male born with hemophilia within a family pedigree. Based upon the WFH global estimate of 400,000 people worldwide with hemophilia, this would mean that there are potentially 625,000 to 2 million carriers in the world. If one assumes a robust outreach and genetic counseling program is taking place, and we utilize the definition of those with a factor level of less than 30% of having mild hemophilia, these ratios would suggest that a hemophilia treatment center with 100 hemophilia patients would have between 30 and 100 carriers with a low factor level, requiring an ongoing management for possible bleeding symptoms similar to those with mild hemophilia. To illustrate the significance of these estimates, In regions of the world where there are very large families, such as Iran, 4,000 female relatives have been identified for 1,500 people with hemophilia. Because of the unknown carrier status of grandmothers, mothers, aunts, sisters, daughters, and nieces of a person with hemophilia, they must all be considered for screening to establish their carrier status. Thus, the number of women who would actually need the services of an HTC at least one time within their life to assess factor levels or for DNA analysis to determine carrier status is much higher than the actual number of carriers that would require ongoing support. It will take time to reach out, to identify, and to diagnose all of those in need. A study from the U.S. Centers for Disease Control in the United States, published in 2003, reported that the average length of time from diagnosis from the onset of symptoms was 16 years. This indicates that too frequently, patients with hemophilia, in particular women, go undiagnosed, untreated, or the care for their underlying bleeding disorder is improperly managed. However, in spite of these challenges, the number of women reported with bleeding disorders is growing rapidly in some developed countries. For example, also in the United States, from 1991 to 2007, the number of female patients treated at U.S. hemophilia treatment centers grew nearly 300% to over 9,000. Although the 16-year lag time to diagnosis is troubling, this rapid increase in the total number diagnosed is in fact encouraging. One of the challenges this now presents is whether the hemophilia treatment centers globally are equipped to handle this growth in their patient populations and how best to replicate this trend from the United States around the world. In addition, hemophilia treatment centers and our national member organizations will need to be prepared to support the psychological and the social implications associated with carrier testing and diagnosis. So how best can the WFH increase awareness and develop global outreach, genetic counseling, and registry programs similar to those offered in the more developed countries? One recent endeavor, the WFH collaborated with the World Health Organization in a unique educational and outreach effort to raise awareness of the risks of postpartum hemorrhage and maternal death. Keep in mind that maternal women will first present in another care setting other than an HTC with pregnancy or during childbirth. PPH remains the main cause of maternal death and long-term disability for women around the world. PPH occurs in approximately 14 million worldwide in women. While delayed or secondary PPH is rare, occurring after less than 1% of deliveries, it has in fact been reported in 20 to 25% of von Willebrand, 2 to 11% of hemophilia carriers, and 24% of women with factor XI deficiency. The WFH co-sponsored this WHO meeting to highlight the critical role of the clinical management of bleeding disorders in a maternal health setting. We must develop new and innovative ways to reach out and serve women in need. In fact, a number of outreach programs have been established, such as Project Red Flag in the United States, the women's programs of the Canadian Hemophilia Society, Women Bleed Too in the UK, and others. They've been created to raise awareness and to improve the quality of life for women. However, to date, these programs have not been tested or optimized for use in developing countries or within diverse cultural communities. In addition, the WFH has developed a number of educational resources, guides, dedicated websites, and outreach tools for both patients and clinicians. Nevertheless, it is becoming clear that these traditional educational and outreach tools may not be optimal approaches to identify the women other than those with hemophilia, particularly in settings where open discussion about menorrhagia, family planning, or when having a conversation with a male healthcare professional is unfitting. Innovative strategies and tools are needed to reach the vulnerable populations. we must reach out and work through other healthcare settings outside of the Hemophilia Treatment Center network. To address this need, the WFH piloted a development program with the Lebanese Hemophilia Association and the Ministry of Health in Lebanon. Following the diagnosis of hemophilia cases in the Bekaa Valley and the Accra regions, a project to identify von Willebrand patients has been initiated, working through community health centers of the Ministry of Health. To date, 9 patients have been found. Other pilot projects are being launched in Egypt and Mexico. We'll report the results soon. Given the many settings in which women will first present with bleeding disorders, a multifaceted outreach and educational approach is required. The results of these initiatives will be evaluated to inform planning for future WFH global initiatives and design programs for our national member organizations to implement within their countries. Having recognized the critical importance and awareness that's needed to be paid towards women with bleeding disorders, the next crucial steps to close this care gap in our global family include achieving a better understanding of the true incidence of carriers, the development of outreach and registry programs which can be advocated globally to educate and guide women to an appropriate clinical care setting. In parallel, it is important that we develop educational and training programs for our national member organizations, as well as improve the clinical expertise within the Hemophilia Treatment Center network. And equally importantly, we need to increase awareness among the broader medical community, family practitioners, nurse midwives, obstetricians, gynecologists, and community health centers. They will all be strategically important and central to our outreach efforts. So let's turn our attention to the sub-Saharan African region.